there's a clinical translation gap, right? And in medicine, it takes about 10, 15 years of basic science research to translate into clinical application. So doctors are always very slow to adopt and change. There's so many examples, but like the perfect example is with like this whole functional medicine stuff, which has been going on. Some of the leaders in the space have been talking about a lot of the stuff that mainstream media is just talking about now, or mainstream medicine is just talking about now, but they're like 10 years behind.
Welcome to the show, Dr. Khan. It's a pleasure to have you.
Yeah, thanks for having me.
So I just want to get started with you. Like, how did you get into medicine? Like, what was your kind of inspiration or your motive?
Well, as you know, I was very into health and fitness. So I was actually a personal trainer before I went into medicine. So I was always kind of interested in the preventative side. And I enjoyed training, but then I was kind of like, okay, it's not really intellectually stimulating enough. And so I wanted something a bit more challenging. And so naturally I just gravitated towards medicine because it was an opportunity to help people, which, sounds very simple and cliche, but literally that's why I went into it. But it just ended aligned with my interest of like health and fitness, and then something that was challenging as well. But then once I got into medicine, I realized we were doing a lot of symptom management and a lot of just, treating disease and not looking at the root cause of disease, also not looking at how we can prevent disease. In fact, all of medical school, we had maybe one lecture on nutrition and, we had 0 lectures on exercise. So it was pretty comical to me as someone who was a fitness trainer that we're not actually talking about the root cause of why people have, high blood pressure, diabetes, coronary artery disease, cancer, which are like the big common diseases, and why we're not actually looking at preventing those. So even though I went into medical school and I trained as a medical doctor, I was concurrently studying integrative medicine and functional medicine. And then once I finished, then I got into regenerative medicine because that's become a lot more mainstream now. And there's a lot more research on that. And obviously we're going to talk about that. But yeah, so even though I am a medical doctor, I would say I'm trained more holistically than most medical doctors, just because that's always been my natural interest. And I feel like I can make a much bigger impact on someone's life if I can get to the root cause, or if you can even prevent it to begin with, which is why, I go on social media and all that stuff.
So what made you go into, because you actually specialize in interventional orthopedics.
Yeah. So
is that like one of the main subspecialties within the medical? Because it's different I think in the US, they've got different names.
They do. And there's other names for it. There's interventional physiatry or interventional pain. But our specialty is a little bit different because it's kind of a combination of a whole bunch of different things. So it's technically interventional ortho-biologics, but what that really means is we're just combining the interventional injection approach from interventional pain and sports medicine, but we're using ortho-biologic substances, which are basically substances that can promote healing in soft tissue and joints and ligaments and nerves. So instead of just trying to mask the pain or reduce pain, we're actually trying to treat the root cause of the pain. And we do that using plasma injections, stem cells, something called hyaluronic acid injections. And there's new generation of stem cells now too. So there's a lot of new options, which is why it's such an exciting field. And I'm also doing clinical research, and I'm one of 3 doctors in Canada approved to do stem cells right now because I'm doing a clinical trial using stem cells for osteoarthritis.
I'm quite interested in that field myself because coming in from the pediatric field, I've always had an interest in using regenerative medicine for use of diabetic foot ulcers. Mm-hmm. So I've got questions to also ask you more about the kind of process, and also because of your research, talk more about that. But taking a step back to people who don't know what regenerative medicine is, can you give a brief kind of like outline or introduction into it?
Yeah, so the promise of regenerative medicine is really to restore tissue back to its previous state or function. So essentially what we're trying to do is take damaged tissue or even a damaged organ and try to repair it back to its previous state. So that's kind of the holy grail of regenerative medicine, and that's what we're working towards. We can't do that with everything yet, but we have come a long way, especially in the last few years. But for the most part, where regenerative medicine is right now, it's more anti-inflammatory and treating inflammation, which can still be great, and it can promote regeneration, but you can't always restore tissue back to 100% previous state yet, although there's a lot of research being done with 3D bioprinting, where you can, essentially we're working on trying to print organs or print scaffolds and then seeding them with stem cells so you can actually regenerate new tissue. So that's really what regenerative medicine is all about. So instead of just cutting something out, we would try to restore damaged tissue to its previous state.
And what was the first basis of regenerative medicine? in stem cell therapy?
Well, regenerative medicine really started in 1992 by a PhD from Case Western University named Arnold Kaplan. He was the first one who coined the term stem cells. He coined the term using mesenchymal stem cells, and he kind of figured out the cell lineages that they turn into. But since then, we've come a long way, and we realized that the term, and he even wrote a paper about it about 5 years ago, saying the word stem cells is a bit of a misnomer because they're not true stem cells. They've already differentiated a little bit. So they're more what's called committed progenitor cells, which means they go down a certain cell lineage. So a true stem cell is a stem cell that's completely undifferentiated and can turn into any type of tissue and has like a very high self-renewal capacity. There's other specific criteria too with like CD markers and stuff, but that's very technical. But the point is a true stem cell is a stem cell that can turn to any types of tissue. And most stem cell injections done in the US today are not true stem cells. In fact, there are no stem cell injections being done in the US outside of clinical trials. So unfortunately, there's a lot of misinformation and a lot of bad marketing and bad people in the space who are taking advantage of people. And because I am a clinician scientist and I'm doing research with scientists, one from U of T and one from Harvard, I happen to have access to some of the best doctors in the world. And so I can really tease out and get the right information out there to people. Because right now, like when you go to a doctor for stem cell injections in the States, they're just taking your bone marrow or your fat and then processing it and injecting it back in. But those aren't true stem cells. Those are what are called committed progenitor cells. They send signals that reduce inflammation, and that can help with pain, and they can still work great, but they're just not stem cells.
Yeah, it's just no different to PRP.
Mm-hmm. Exactly. It's just like a stronger version of PRP.
And it's safe, but the efficacy is not strong enough for what it's designed for. Its branding and almost ineffective for what it's actually aimed at. And I can see that with a lot of other people in alternative medicine actually doing some of these treatments in the US, which I did a podcast with another spine surgeon who also talked about like the dubious treatments out there where people get scammed into paying for these ineffective treatments.
Yep. Exactly. And that's the problem. There's no regulation. The FDA tries their best, but honestly, there's just too many pop-up clinics. So it's like the wild, wild west out there. Canada has a similar issue too. Like the regulation here is very poor and there are a few doctors doing it illegally, but no one has stopped them. And it's a problem. And then now with Colombia and, BioAccelerator, Panama, and these guys where there's zero regulation, there's just people going there for all sorts of stuff. And it's just a shame because people spend a lot of money and they're given false hope, that they can cure multiple sclerosis or cancer or paraplegia, like stuff that's just not proven, There's certain things that stem cells can work for, but other things it can't. And we need to know where the boundary is so that people don't waste their money and energy on going down those routes.
And another aspect is because I actually was involved in studying some of the aspects of regenerative medicine. And one of the materials that was actually considered to be used was called Wharton's jelly, where you're basically using a donated embryonic jelly material. And it's actually then not manufactured, but it's processed in a laboratory where it's almost like a dressing. It comes in a sheet. And what you can do is you can actually replace damaged tissue with this. So, for instance, if you have a diabetic foot ulcer, you pretty much, your skin is fragile even when it heals. So a lot of your tissue is actually being lost in that process. So the idea was like you're replacing like for like tissue. But again, it's still actually in trial phase.
Yeah, it's good you brought that up because there's a lot of different types of stem cells. We were talking about earlier, when you take your bone marrow or your fat, those aren't true stem cells. So true stem cells, or the closest thing we have to true stem cells at this point, are what are called perinatal or fetal stem cells. So there's purified amniotic fluid, there's placental tissue, and then there's umbilical cord blood and umbilical cord tissue. So umbilical cord tissue is the gelatinous-like substance, and that's called Wharton's jelly. And there's different processes to harvest that Wharton's jelly. And I'm actually working with a company called Neobiosis, Dr. Ian White. He was recently mentioned on Joe Rogan's show too, because Brigham, his buddy, was on there. So we're working together because he has a proprietary method on harvesting the Wharton's jelly to increase its viscosity. So it has an increase in growth factor. So it is important on how you harvest it and process it. And that it can treat severe burns. It's helped stroke patients. It can really do a lot of different things in terms of regenerating damaged tissue and inflammation. And then what we're working on expanding the stem cells, where we actually grow them for 4 weeks, and then you increase the cell count. And the idea is that eventually we want to get to a point where we can say, okay, this pathology needs this cell count, and that's what's going to work for this. And once we can do that, then that's where you get into, it's almost like a drug therapy. And then you can actually get hopefully insurance to cover it. So that's our long-term vision, is to actually standardize the process and make it a cell count and an actual viable treatment, as opposed to just something like being like, oh, we'll put these stem cells in you and hopefully they'll work, which is where we're at right now. And unfortunately, but the science is evolving, and it's going to keep getting better and better. But even with where we're at now, we're getting good results, but there's a lot of heterogeneity in terms of the response and the data. So we need to standardize the process.
Absolutely. And that's something I would like to discuss with you later on off the podcast, because that's like my main field of interest. And like I said, it's in a trial phase. It needs to go through a trial phase. Particularly in the UK, there's a lot of groundwork that needs to be done. But in the US, physicians and surgeons have actually been using it. And it's kind of controversial because there was a new law passed, which is actually because they were using Medicare to use the treatment and claiming it for Medicare, which was actually looked at illegal. So a lot of physicians and surgeons have been using it, but there's a recall, and none of them actually now just giving the money back. What about in Canada? Has that ever been in use yet? And what are the legal aspects and ethical aspects of it?
Again, I don't think that's necessarily justified. I think, in every other developed country in the world, it's legal. Japan, China, Germany. So, it's just Canada and US, unfortunately, have very strong lobbies when it comes to surgeons and to drug pharmaceutical companies. And they definitely, lobbies get a lot of say, and they have influence on the FDA as well. And Brigham goes into detail on Joe Rogan's podcast. But so if you guys want to check that out, you can check that out. But basically the point is there's a lot of people trying to suppress their information, and they make it even illegal for us to advertise or promote stem cells in Canada and US for now. I can promote them in Canada because I'm doing a clinical trial, but I'm the only one, and a few other docs who can do that. But in US, it's the same thing. You can't promote you're doing stem cells unless you're doing a clinical trial and you're recruiting patients for it, which doesn't necessarily fall in line with the data. I think we have enough data to know that it works for osteoarthritis, it works for chronic pain. But yes, when it comes to neurological conditions, we do need more research, but there's a lot of good data. And in terms of like stroke, inject into spine for ALS patients, slowing down the progression of it. And then, so there's an evolving field. And the other thing too is, a lot of the conditions we treat, there are also no other options. So especially what I see people from around the world, and most of them have seen multiple doctors, and they're kind of coming to me because they're like, there's nothing left. And, they've tried everything, or sometimes even surgery. So it's like, what else are you going to try? And this intervention has, pretty much no harm, and it has a lot of potential upside. So I think in medicine, we often talk about evidence-based medicine, which is like, number need to treat, number need to harm, which is basically risk benefit in layman terms. And you have to look at, whenever you're doing an intervention, what's the harm that can be done and what's the potential benefit. If you're giving, for example, let's talk about rheumatoid arthritis, which is very common and a lot of people have it. If you're going to give like an immunosuppressant drug like methotrexate or, something like that, that's really going to maybe increase your risk of cancer. That have to back that up, right? And so it's kind of like a sliding scale versus something like IV stem cells, which has been shown to be effective for rheumatoid arthritis. There's case reports and published data now on it. It's a one-time infusion. There's basically no downside to it, and there's so much upside. So, what intervention are you going to consider? If it was my mom or parent, I'd consider that one before I'd go put them on methotrexate. But that's where I think medicine, the EBM model kind of falls apart. It's just, it looks very black or white in terms of like looking at an intervention and the data around it, but you have to look at the harm too, not just the benefit.
Yeah. A few questions pop up doing that. The first thing I wanted to talk about was like the aspect of using it within treating, for instance, rheumatoid arthritis or even osteoarthritis, if you want to make it more simple, where if you have osteoarthritis within your knee, afterwards it's just wear of the joint, the synovial fluid basically runs out and it's just bone eroding itself. So there's nothing you can do apart from have a knee replacement surgery. And that's gone better over the years. I mean, a few years ago, the success rate was very low, but now that's gone high. But if you have to think about that for aspirin, that's the only thing that's available. There are only a few treatments out there, but now you have this, what we call regenerative medicine, for instance, like Wharton's jelly, which can be used to replace a damaged tissue. That's a game changer. I mean, I think about my parents or myself when I'm older, about.
Okay, do you want your knee cut out, or do you rather have some stem cells?
Because
for me, the answer is easy.
Yeah. Because even if you do have the operation, I remember it would last for 10 years. So that's why we would always kind of push it towards the end as patients got older.
And like you said, knee replacements come a long way, but still it's like, it's not 100%, it's like 80% is like satisfaction rate. And then in terms of like elbow, ankles, like shoulders, like those are not good. Have all these osteoarthritis and other joints where it's just like they have no option, right? As like just like you can't take pain meds, as we know, have so many risks with them, and like it's in fact, I'm doing the treatment for my parents because I believe in it that much. Like I know it's effective, and my mom has osteoarthritis, so it's easy for patients to buy into it too, because they like, oh, if you're doing it for your own family, then obviously like there's something that you trust it and you believe in it. Plus, like I said, there's so much emerging data. The problem is there's a clinical translation gap, right? And in medicine, it takes about 10, 15 years of basic science research to translate into clinical application. So doctors are always very slow to adopt and change. There's so many examples, but like the perfect example is with like this whole functional medicine stuff, which has been going on. Some of the leaders in the space have been talking about a lot of the stuff that mainstream media is just talking about now, or mainstream medicine is just talking about now, but they're like 10 years behind. But it's like the functional medicine community, it's just they're always going to be slow to adopt and change, just because it's like any institution. They're always very they just love bureaucracy and a lot of players and politics and all that stuff. But yeah, the regenerative medicine stuff is really cool. Just so people understand, like, to regrow tissue, like we're talking about, you have to use real stem cells. But also there's something called a regenerative medicine triangle that we say. So there's three things you need. You need a scaffold, and then you need progenitor cells, and then you need growth factors. So those are the three things you need to really regenerate tissue. So that's where 3D bioprinters come in with the scaffold part. And then obviously the growth factors and the stem cells come from the actual stem cells because they have growth factors in them too. But sometimes we might put PRP with it too because it has growth factors too. So that's how we achieve regeneration. And so there's actually been, like you were saying about the knee, there's an orthopedic specialist out of University of Washington, polymer scaffolds. So they actually print them and then they seed it with stem cells, and it can resurface an entire joint. So instead of getting a hip or knee replacement, you could just resurface it and grow new cartilage. And that's already an FDA clinical trial, and it should be approved within a year or two. I'm hoping to use that hopefully in the next 2 years too. And so I'm excited for that, because that'll be like the holy grail, where you're actually resurfacing an entire joint, and not just growing a little bit of cartilage, or regrowing everything. So that's where medicine is headed, and it's gonna really decentralize and disrupt the model, because it's going to take it away from hospital model base into more clinical community base.
With regenerative medicine, it's new research that's coming in. A lot of people don't know about it, but what people actually do know is the stem cell therapy, where you do PRP style treatments.
Yeah, the problem is there's a lot of research out of Asia that doesn't necessarily get translated here, and a lot of people don't realize how much stuff is actually going on and how many clinical trials. For example, with long COVID, or even an over 40 randomized trial using allogenic stem cells, which mean from healthy donors, and they've all yielded positive results to help with long COVID and even acute with the cytokine storm. So that data just doesn't get out as much as it should, because if you remember during the height of COVID and even in the last year, you don't really hear anyone talking about stem cells for COVID, although it has lots of data and research behind it. And it's in fact going to be the standard of care moving forward. And there's a product that's coming out specifically using amniotic cells or amniotic fluid to treat long COVID. So it's the way, especially for chronic disease, this is a way to go.
And how do you get involved within this research field, this study?
I guess I was doing some cutting edge work, and it just started spreading. And then this person just kept going. And then before I knew it, a scientist heard about me, and I was getting recruited to work with them. And then now I'm here, and I'm just, even because I'm, obviously I'm not that old, but I have probably the experience of someone in their 50s or 60s in terms of like stem cell and regenerative medicine, because I also had very good mentors who are in their 60s, and I've learned through their experience and what they know and their years of experience. So I happen to know a lot because of good mentors, I think, is the biggest thing. But it was just, a lot of it was because of Dr. Anthony Gallia. He was my main mentor. He was actually the first one in the world to do platelet-rich plasma injections for musculoskeletal conditions. If you Google him, you can look him up. But he treated Tiger Woods, Alex Rodriguez, all the big U.S. athletes used to come down, or he'd just go to them because he was the first one to do it, and he started it all. But a lot of people copied him, and with the PRP now, everyone's doing it, but there's lack of, again, standardization. So not everyone's doing the right type of PRP, which is why we have our own proprietary. Point is, Dr. Gallia is the one who got me into it, and then he's focused more on the PRP stuff, and I'm focused more on the stem cell stuff now.
And you said that you're one of the 3 physicians who's actually doing a trial. Is that in Canada?
Yeah, Canada's very behind, unfortunately. So it's cool when you say it, but at the same time, it's kind of sad because we should have a lot more doctors and people doing stem cells in Canada, but they're just so strict about the regulation. And so I'm one of the few doctors who has approval.
And the trials that you're involved in, what aspect you're using this as application for? Is it for certain areas within the body?
Yeah, it's for osteoarthritis, specifically for hip and knee osteoarthritis. But we're applying for more clinical trials to use it for every osteoarthritis joint in the body, including back. And then I'm also in the process of using umbilical cord stem cells and applying for studies for line issue and fibromyalgia using IV stem cells. So we're in the process of just getting Health Canada approval for those two.
Could you just repeat that again? I think it cut off a bit.
I was just saying we're also in the process of using umbilical cord stem cells and purified amniotic fluid, so perinatal tissue, basically, for chronic disease as well. So we're just applying to get approval using those products to treat spine conditions and chronic pain, and even like fibromyalgia and rheumatoid arthritis and stuff like that. So hopefully we'll have approval for that next year.
Are you able to talk about some of the trials that you've been doing and how you've been using it?
Yeah, the main trial we're doing right now is just for osteoarthritis primarily, of various joints, and it's what we talked about earlier, the bone marrow or the fat. So it's not really true stem cells as we've already talked about, but unfortunately, the vernacular and the nomenclature as it explain patients know that's a cell, to explain what's progenitor cell. So usually I still use the word stem cell, although it's not technically correct. Even the study is called stem cell injections for osteoarthritis, but that's, again, just Health Canada, the people who approve it there aren't necessarily the most knowledgeable either. But it's a shame because the word stem cell probably shouldn't be used, but people just use it. So, but we're using for osteoarthritis, and so far, all the patients I've treated have had great results. Like, it's been great. So it's very encouraging and this is just generation 1 of stem cells. But usually it's, more moderate osteoarthritis that patients are. So there's been a few advanced ones. But yeah, it's exciting that we're getting good results with that.
Can you talk us through an application of how we'd use it? For instance, if you had someone who had osteoarthritis within the knee, how does it work?
Yeah. So, I mean, it's actually pretty simple. And if people with the HC muscle interested in treating stuff like that, but basically, you come in and you randomize into 2 groups, either the fat stem cell group or the bone marrow stem cell group, and then so depending on which group, we're going to harvest it from your body, either from your fat or your bone marrow. People always think bone marrow is going to be more painful, which it is a little bit more painful, but we do use a lot of anesthetics, so it's not bad. But basically what we do is for fat, we, freeze the area usually on the handles on the sides, so most people have enough fat there. And then we just put some freezing and saline, and then we mechanically break up the fat, and then we're able to harvest it using like a suction. And then we just centrifuge it and spin out the part that's called the stromal-vascular fraction, or SVF. And that's where the progenitor cells are, and all the growth factors and anti-inflammatory cytokines, which are like signals that reduce inflammation. And then bone marrow is similar. I get just, some local anesthetic, and bone, the drill, and we use ultrasound too for both procedures to make sure we're going in safely into the right spots. So it's a lot more gentle, because I know some orthopedic surgeons who do it, they'll use a drill, but that can obviously be harsher on the bone. So we just, once we go into the cortex, we just kind of puncture it a little bit, and then we can just suction out the bone marrow, and then just process it and inject it back in. So the whole thing only takes like an hour and a half, and most people are sore for a couple of days, and then they're good to go back to normal activity. So when compared to surgery, it's a huge less recovery, and also minimal downtime and minimal risk and all that good stuff. So the demand for it is just going up and up. And as more people find out about it, more people are going to keep doing it, because, the alternative is, like we said, it's essentially just cortisone or surgery. And cortisone is just a Band-Aid, which can be toxic to cartilage anyway. So it's not like something you want to keep doing.
Yeah. And not only that, it also increases your blood sugar levels, which I've actually seen where patients have actually started developing type 2 diabetes because of cortisone injections.
Yeah, because the doctor never told them, if you keep getting this, it might increase your blood sugar, and they're never even given proper informed consent about all the risks.
Yeah. And this is actually the phase 1, where we're actually taking the fluid out, for instance, from the person's bone marrow, and then we've actually then adding stuff into it, just to, on a layman's terms, people understand. And then we're putting it back into the person, whether it's the hip joint, the knee joint, and that basically allows the joint to repair, to heal.
So the way it works, so the way these injections work are what's called immunomodulatory. So they basically send signals through your immune system through what's called the monocytes that anabolic factors, which are growth signaling factors. So all it's doing is changing the environment, because we know there's recent studies that have been published using fluorescent radiation dye, where they look at how long the stem cells actually stay in there, and it doesn't stay, for the most part, it doesn't stay there more than 2 or 3 weeks. So they're not there for a very long time. So it's like, how do they exert their effect for years or even permanently? It's because they send signals to your body's own endogenous stem cells and your immune system to keep on secreting these growth factors. So it's actually changing the environment of where they're being injected, which is why there's another recent published data. It's an animal model, but basically showing that it can delay the progression of osteoarthritis too. So it can be used even prophylactic in some people. And with some of our athletes, like, for example, like LeBron James, like I know his doctor in the States, and he has stem cell injections done usually in the off season, just because he has some mild thinning of the cartilage,
So what's the success rate that you've seen in your trials from people using this? Obviously, taking into consideration the conditions beforehand.
Yeah, exactly. So there is definitely a bit of selection bias, I guess, because most of the patients we get are moderate to advanced. If it's very advanced, then it's a bit more, not a guarantee. But so far, everyone's gotten better on our trial. But in terms of like more long-term data and other trials that have been done, it's usually 80 to 90% success rate for moderate to advanced osteoarthritis. But if you have like bone-on-bone osteoarthritis, then the only thing that can really help with that are second-generation stem cells and what's called subchondral or intraosseous stem cell injections, where you actually inject into subchondral bone. So there was a study in France that was published. It was a 12-year follow-up, so it was a really good some of the subbone, and they compared it to a group that had knee replacements. And at a 12-year follow-up, the group that had knee replacements, 6 people needed revisions, and only 1 in the stem cell group needed revisions, like a surgery. So it's pretty amazing that they can last that long when they're done properly with good technique and all that.
And have you published any papers before, or have you been involved in any publications?
Yeah, I was the first doctor in Canada to publish a paper on intraosseous plasma injections, which is the subchondral one. So before I was doing stem cells, obviously I was doing a lot of plasma. And I used that to treat advanced OA, avascular necrosis, and stuff like that, and had great results. And so I published and presented that recently. But and then we're going to be doing a lot more work with the umbilical cord stem cells, and I have like probably 6 or 7 papers that are in submission that need to be wrapped up and stuff, because I do a lot of unique things. So there's a lot of case reports we're publishing.
Yeah, and what I've realized is there's a lot of papers out there, but they're not good quality in terms of the selection. Very vague. I've read some papers within the use of the Borton's jelly itself, I'm not seeing, they're not very well grounded sort of like data to be used.
Yeah, the problem is it's not like big pharma where you can have like, you know, $1 billion dedicated to a trial or something, right? And this is you can only do so much when you're either a small startup company that's manufacturing these cells, or if you're just like a doctor working community and you want to get some research out there. I don't think you'll ever have as robust data as you do in the pharmaceutical industry. However, having said that, I don't think you necessarily need as much, because again, the harm with these safety data, just need more efficacious data, which there's a lot of trials being done around the world. So it kind of adds up, you know? So just like 30 patients here, 30 patients there, and then just over time you get hundreds and thousands. So there is a lot of that data being published now. There's a great one recently that was a 5-year review of expanded stem cells from New Zealand. And they published, you know, I think it was at least like 500 patients. So it's a pretty large data set. And they had about like 80% success rate with advanced OA. So it's pretty good to see that.
And one thing I've realized, I mean, I don't know about yourself, did you actually study on how to critically evaluate papers when you were in med school? Was it part of your education?
Yeah, it was. It was one of those classes most people just hit the snooze button on, unfortunately. So wasn't the most exciting, but I took it upon myself to, there's this other podcast out of Canada it's called Tools for Practice, and they have a really good evidence and, you know, odds ratios and stuff like that. But I think the biggest thing with evidence is the problem is you have to look at the quality of what they're actually doing. For example, PRP is a perfect example. Like the literature is all muddled and messed up because half the time they don't specify what type of PRP they're using. They don't standardize. Sometimes they don't use image guidance. So of course, if you're going to do a meta-analysis on all these crappy studies, then the meta-analysis is going to show poor results too. So you have to actually look at what the intervention was and if they did that intervention even properly. And that's the problem with regenerative medicine. There's no standardization. And so there's just all this, people are just doing different protocols and people are doing different things, and it just leads to mixed results. So that's where we're trying to come in from the perspective, say, hey, like we got to measure our cytokine profile with the PRP, and with the stem cell, we got to have a cell count, and we got to standardize this. So that's the direction we're trying to go in. And once we have a standardized process, then I think it'll be the results. I think we're there, like, you know, from like, you know, who's getting treated by this, like everyone's already kind of doing it and it works. You know what I mean? It's just some of the academics are skeptical because they don't do it. And so they just kind of want to see more data. But it's hard to argue with thousands or millions of people at this point who've had it and got better, you know?
Yeah, that's the thing. It's more anecdotal, and you're seeing this in your practice. But the thing is, what I've realized is there's a lot of, not necessarily for regenerative medicine, but just generally, there's papers that get published and then they get onto newspaper outlets, and then you see other doctors who then use that and use it as evidence. But when you actually break down the paper, we've seen a lot of examples of this on TikTok. There are a lot of debates that go on. There was a recent study on patients who were using mouthwash, where it actually increases the risk of heart disease. But when you actually break down the paper, these patients already had predisposing conditions in the first place. So for a healthy individual, it wouldn't have any impact. That's just a fine example of that. I mean, go ahead.
No, yeah, exactly. And that's the problem is, you can pretty much play a lot of statistical games, and you can not make up, but almost kind of support your point. If you're keen on doing that, you'll find something to support your point on anything almost. But that's where reproducibility comes in, and I think that's by far the most important factor in research. Is there multiple independent groups coming up with the same results? And if there is, then it's probably something worth looking into and something that's probably has merit. But if you can't replicate and you can't have multiple people coming up with the same findings or the same results, then it's probably just some research. And that's the whole thing. So reproducibility, I think, is the key for people to remember. You're always going to do research clout, but a lot of it is just for clicks and for headlines. The fundamentals haven't changed, especially in medicine, like nutrition, exercise, all that stuff, right? Like people, the data is already out there, but there's always going to be people who want to make more content. And in order to make more content, they have to just like get clicks and get whatever headline is out there.
And there's never been any time in history, like right now with TikTok, we've seen a lot of medical influencers coming in. In fact, there's a new term called medfluencers. It's just interesting because the last sort of 5 years, there weren't that many medical influencers. Now there's so many.
The problem is a lot of these doctors who are, I mean, I guess I'm, because my Instagram, obviously, I have a decent amount of following, but the thing is, it's also who follows you and who you treat. And like, are you kind of actually the best at what you do, or are you just kind of like, and the post doctors on TikTok and on Instagram is that they're not really experts or they're not really world class at what they do. Yet they go around talking about a lot of things. So that's where the disconnect is. And the best doctors in the world, who I'm like I said, because of who I treat and who I work with, they go on TikTok, like have better things to do with time, and they're busy and they're treating the highest profile people. And we're kind of, there's a group of elite doctors who work with those people, and they're not really on TikTok.
Definitely. I mean, I was saying that to my wife as well. Like the best doctors, they don't have any time to make videos, to make YouTube videos, TikTok videos. They're busy working long hours, so.
I'm just making now that I'll be treating a lot of high profile, I'm treating a lot of I'm just making content around that more or less now. And, people see my journey and how I'm traveling around the world and treating like celebrities. That's just my way of, but I like to give back, which is why I do social media, is just to give, kind of get rid of all the misinformation and nonsense out there. But it's hard to fight with a lot of the people who just put out like lots of content, but not quality, but the good thing is, like, at least in my case, I found that because a lot of the biggest fitness influencers and the industry leaders follow me, I don't need to have millions of followers. For me, I have people who have millions of followers who follow me, especially on Instagram. Like I get like all the big names in the fitness and health industry know me. And so that's why I treat, that's why I'm treating a lot of the biggest names, is because people know who I am, and I don't need to, I just find a lot of people on TikTok they're trying to sell themselves, or trying to like present something, like they're experts on nutrition when no one in the nutrition field really respects. And that's the thing, people in the field and the experts actually know who each other are and they respect each other. And that's, at least that part won't change.
Another topic that you mentioned, because it was on your TikTok video where you mentioned about diet and food choices. For instance, like a Mediterranean diet wouldn't be probably the best choice for people who are South Asians, for instance, or East Indian, because the data, for instance, the Mediterranean diet was done within the Mediterranean area, which is Italy, France. Those people were actually getting food from the source within the land. But there's a big hype now on the Mediterranean diet, especially within the CDC recommendation. It's being pushed everywhere.
It's not sexy. It's not sexy if I just tell people, sorry, Mediterranean has the most evidence for heart disease, cardiovascular reduction. It's not going to give me a lot of views, which I don't care about, but a lot of people do. And so they're going to or keto or whatever the latest trend is. And unfortunately it's, it's just a way to get clicks, but there's nothing that has more evidence than Mediterranean diet by far. The reason there's variation though and customization is because like you said, studies have primarily been done in those groups. So ethnic groups like South Asians, like our blood vessels and our arteries and how we respond to foods is different. And so some of us may do better with a lower carbohydrate, higher protein, higher fat diet. But that's where, I think doing functional genomics like DNA figuring out what type of nutrition plan works for your based off that and blood work and continuous blood glucose monitoring is the best way to go. Because then you actually can individualize it, right? You can say, okay, these type of foods work for my body and these type of foods cause more inflammation or cause more likely to cause blood sugar spikes and stuff like that. So it's not a sexy approach though to say like, oh, you have to really do work to figure out what best diet. Oh, keto, because I'm doing keto, you should do keto. Keto work for me. And that's just the way it is now, which is unfortunate, but there are good people in the industry who are trying to do good work. So, but I always find the people who are doing the good work never have as many views as the people who are just kind of out there and loud.
Yeah, there's always a saying where the stuff that is being put out, like there's a lot of dubious treatment discussions within TikTok. There's a lot of people putting information which is no evidence-based medicine, yet it gets a lot of views, especially within the alternative medicine field. And then you look at people who are actually preaching the truth. And that's where my next question comes in. There's always this aspect now within functional medicine, which is alternative medicine, where they poke holes within traditional medicine saying that doctors don't treat the cause, they treat symptoms. Yet a lot of these conditions, we don't even know what the causes are. There's just not enough evidence or research done. It's not come there for a lot of diseases.
Yeah, and that's why there's so much debate about what the best treatment plan is. I bet you if you go to 3 different functional medicine doctors, they'll make 3 different treatment plans. And I think that speaks for the field itself, right? We just don't know. And it doesn't mean functional medicine is nonsense. It just means we need more information and more research, right? And that's just the way it is right now. It's like there's no standardized algorithm. I know some people who are working on that, but I think it's still a few years away.
Yeah, but I've also seen a lot of MD doctors who actually use alternative medicine. For instance, within the UK, I knew of a general practitioner, which is equivalent of a primary care physician in the US, who actually did further studying into homeopathy, but only used 1 or 3 selective medications for pain, which were shown to be quite effective.
Yeah, no, that's so. Yeah, like homeopathy is just something I never really understood. And I think you always have to come back. I think the biggest takeaway I can tell people when evaluating information is come back to first principles, which is basically come back to the fundamentals of how things work. So what's the actual mechanism and what's the actual basic science behind it? And most people actually don't understand that stuff, especially a lot of doctors don't understand that stuff, which is why, with regenerative medicine, a lot of people just don't get it because they don't understand the cellular pathways and the cellular mechanisms and all that stuff that we're trying to achieve with it. And it is pretty dry information, but it's something that's like fundamental. It's like the principle, the foundation of understanding everything we do, especially now as medicine gets more complex. If you don't understand cellular, that disease starts in the cell, lost at this point. You're just kind of, you have to first have that fundamental understanding that disease starts in the cell and about mitochondrial dysfunction, epigenetic alterations, telomeres, cellular senescence, all that stuff, right? And if you don't understand those principles, then you're really not going to have a good base of understanding disease, at least chronic disease.
Within your field where you work practice, what are some of the things that actually do work in terms of treatment choices for pain? For instance, osteoarthritis in the knee or even the hip.
Well, for degenerative conditions, stem cells work great. I've had great results for that. PRP works really well for muscle tendon tears, but for degenerative chronic conditions, whether it's tendinosis or osteoarthritis, the stem cells are the way to go. Even the first generation stem cells work flat, but secondary, I haven't seen anyone not get better. You know what I mean? And it's just it's one of those things where I find everyone gets better with pain and inflammation. It just works so well for that. So I'm not hesitant to recommend that stuff for those people because I've had so much experience with it and I've seen so many positive outcomes. And yes, maybe we do need more data, but as a practitioner doing this in the real world, I know, I've seen enough that I know it works and then I can be confident to recommend it.
And what about for back sort of pain, for instance, like sciatica, radiculopathy?
Yeah, so for that, it depends on as long as they don't have any neurological defects, like, really bad motor symptoms or atrophy where they're losing muscle, usually we can repair it in what's called platelet lysate, LYSATE. That's a type of plasma injection that's more anti-inflammatory, and it's been shown to help with reducing disc bulges and herniations, and it can help the nerve to reduce nerve. We do platelet dissection. That 8% of the time, majority of people get better. If it's really severe, then sometimes we'll do the stem cell injections, and again, that pretty much always works. But we're doing the epidural. We use an X-ray machine and we guide it using we go into the epidural space. So it's very precise and image guided. It's not like we're just putting a needle in haphazardly. So that's why there's only a few specialists who are really trained to do this stuff. You can't just go to like some doctor who dabbles in it. You have to really have the image guided skills and fluoroscopy, X-ray guidance, and ultrasound too.
Yeah, particularly knowing in your field of medicine, no matter, depending on what area you're in. For instance, if you're within a podiatry field, then you'd already specialize within the ankle.
I pretty much treat everything from head to toe.
So you've probably got a good understanding of where the problem is in each anatomy sort of aspect.
Exactly. Yeah. Because it's all precise and targeted.
Gotcha.
And that's the biggest difference, between us. Because again, Dr. Galley was the first in the world to start this. So, as our ultrasound diagnostics are better than, it's probably one of the best in the world, if not the best, and that's why we have people from around the world fly down to see us, is because we can find small tears and we can find things that other people miss. Because the ultrasound is so user dependent on the technician and the technologist. So, we usually do dynamic assessment with the physician in the room, and we get them to do different maneuvers and positions, and then we can find stuff that gets missed. Because MRI is very static, right? And MRI is also just 2 to 3 millimeter slices, so sometimes they can miss small tears. And then depending on where the issue pathology is, you might not find it unless you're doing a dynamic maneuver. And ultrasound technologists are just not trained, and like most of them are just to just do their job. They do their basic scan. So but then still in pain, but what's going on? So that happens all the time.
And how much do these treatments cost generally?
It ranges. It starts around like 700-800 Canadian, which is probably 500 American because our dollar sucks. So and then it could go all the way up to 4,000 Canadian, 5,000 Canadian, I guess, for stem cells.
And is it just one sort of treatment cycle, or would you?
The plasma usually is 2 to 3 for most things, whereas the stem cells is 1. Yeah. And
now, moving on to how can you prevent conditions, musculoskeletal conditions, from forming? For instance, osteoarthritis.
This is where the functional medicine stuff comes in, because they've been talking about this for a long time. But now there's a lot of research that came out this year about the gut-brain axis, how the gut creates actually to the spine and the disc and even in your joints, and how it contributes to inflammation. So it's the same stuff you've probably talked about with other people, and everyone's probably heard is the fundamental lifestyle stuff. It's exercise, sleep, nutrition, stress, gut health, and then and the purpose of that, having fulfillment. So basically, if you're miserable and you're depressed, it doesn't matter how much you exercise, you're gonna have to first figure out your life. There's a fundamental way to go about it. I made a post about the longevity pyramid, and the base or the foundation, I think, is meaning and purpose. Because if you don't really know why you're here or what you're doing, you're just going to be kind of lost. And you can take, and then people do the backwards approach, right? They first start with supplements. Supplements are the absolute last thing you should do after you've got everything else in check. But most people need to work with a qualified health practitioner, a good functional medicine doctor who understands the root cause of disease to really individualized plan for your body, and then you can prevent from getting OA and prevent from getting degeneration. Because even movement, and personal trainers, that's the other big investment into health. The problem, I get it, a lot of stuff is expensive, and that's why the government needs to work on subsidizing and making this stuff more accessible, right? And the problem is they put money into pharmaceuticals and into surgeries, but not putting into the stuff that is really the root cause. If we can get people to move better and learn how to do all those lifestyle interventions, in optimizing gut health, will prevent so many diseases, right? The model and the money's we already know, it's not a question. The economics has already been done on it. It's just, again, the lobbies that are there, they just keep pushing the government in the other direction, a reactive model, right? Instead of proactive.
Yeah. And finally, what 3 pieces of advice can you leave the listeners with?
So one, don't forget your friends. Make sure you spend time with friends. They're the most highs we have in this world, I think. And a lot of people get so fixated, especially with the phone. I feel people, it's almost like you have to fight the phone now because people are so addicted to it and, spend so much time consuming content. But remembering to connect with people in real life, because that actually, loneliness is a better predictor of poor outcomes than smoking. So if you're lonely and you're not connected with people, it's actually quite bad for your health and longevity. And I think people forget that a lot. The other big thing is get strong, because muscle is the organ of longevity, as Gabrielle Lyon says, and that's where she coined that term, but I use that a lot. But because I'm also a powerlifter and bodybuilder naturally, I can tell you that muscle is not just because I'm into that, but muscle releases something called myokines, which are little anti-inflammatory signals that reduce inflammation, help to prevent cancer, protect you from disease. There is nothing on this planet that will protect you more from disease than muscle, like from a lifestyle intervention perspective. And then I think the other big thing is, even though, I glossed over it, but quality supplementation, because you can't get everything through nutrition. So I think just covering your bases and even doing blood tests to figure out what you need, but in general, almost everyone needs vitamin D3 and omega-3 fish oil. And probably most people need a good potent multivitamin just because our soil is depleted. So I think those are like things that everyone can kind of incorporate into their life.
Where can people find you?
I'm pretty active on Instagram. TikTok is more my side thing, just I started, but Instagram is where I live. So it's just dr.akhan, Khan. And I'll be traveling. I'm traveling around the world, Mexico, Dubai, Italy, Florida, and I'm treating a lot of people. So hopefully you guys will see some of that content. There'll be some big names coming through, so it should be exciting.
Well, I hope you enjoyed that journey. Thank you for coming to the podcast, Dr. Khan. It's been a pleasure having you.
Thanks. That was fun. Thanks.